Welcome back to another MDC question style walkthrough. Today's question says a 68-year-old man presented with palpitations and an ECG shown below. 2 years ago, he presented with shortness of breath and had a similar ECG. What is the most likely diagnosis? A. Ventricular tachycardia. B. Atrial fibrillation. C. Supraventricular tachycardia. D. Atrial flutter. E. Sinus bradycardia. And this is the ECG we've been given. Not very clear, but we'll come back to see if we can read it. But let's go back to the question to see if we can pick up some key information to help us answer the question. Right away, the age here, 68, is an elderly man. Advancing age is a risk factor for most medical conditions, so we'll take that, we'll circle that. The key symptom here he has is palpitation. We'll also circle that. He had an ECG, which we've already seen, and 2 years ago he had a similar ECG. We'll also circle that 2 years ago. It could be that the condition is recurrent or is persistent. We were also told that 2 years ago when he had that ECG, he had shortness of breath. So we'll also circle that, something that could be relevant. So in summary, an elderly patient with palpitations now, a past history of shortness of breath with a similar ECG 2 years ago. That is about it. And from the stem, let's go back to the ECG to see if we'll be able to pick up some information together with this, what we've gotten, and see if we can answer the question. Right, so the ECG is not very clear, but if you pay attention to the lead 2, which I believe is probably one of the most clinically important lead on ECG, we may be able to pick up some information on it. It can give information on rate, rhythm, and other information as well, even including axis. But we'll come back to try to read it in detail. But the general approach to reading ECG is that when you are given the ECG strip, you try pick up the demographics of the patient, try to confirm that age, sex, date, the speed at which the strip was recorded. All those are important. But in reading the ECG itself, you always want to go through a systematic approach. And so one is to determine the rate and the rate of the ECG. Now, the rate of the ECG can be determined from any of the leads that have been provided here. The rhythm is best determined in lead 2. We'll come back to that in details. Then you have the cardiac axis, which is also best determined in lead 1 and AVF. Those are the best leads to determine the cardiac axis. You have P-wave morphology, which is best seen in lead 2 as well. PR interval duration best seen in lead 2. QRS morphology and duration, you have to look at it in all the leads. ST segment, you also look for it in all the leads as well. T-wave, you look for it in all the leads. QT interval duration is good on the augmented AVL, which is the best lead to determine the QT interval. Then sometimes your U waves, which you might see an in lead V2 to V4. That's generally the approach. Okay. So the leads, we have the ECG paper we've been given here has all the 12 leads. So you have your 6 limb leads, which are your lead 1, lead 2, lead 3. And you have your AVR, AVL, AVF. Those together form your 6 limbs leads. Then you have your 6 precordial leads, V1, V2 to V6. Those are your 6 precordial leads. And then you have this bottom one here, which is the longest strip, and that is together. That is called the rhythm strip, and this is recorded for a 10-second duration. You need it for you to be able to determine the rhythm of the heart. Okay, and it has to be recorded for at least 10 seconds. And so typically it's an extension of the lead 2. So the lead 2 recorded for a duration of 10 seconds, and which is why I say the lead 2 is probably one of the most clinically important of the leads that you see on the paper in terms of giving you information. And so that is this green strip. So first you need to determine the rate. But before you determine the rate, you need to determine the rhythm, because the rhythm of the heart kind of dictates how you determine that the rate of the heart. Because if it's not a regular rhythm, the reading of the heart rate is kind of different from if it is regular. So let's try to determine if the heart rate is regular. And that is determined using the rhythm strip. So the rhythm strip is this strip that is underlined here in green, and the rhythm is determined by the frequency. So the frequency and regularity of the QRS complex. Okay, so the frequency and the regularity of the QRS complex. So these are your QRS complex. So the frequency, how many of them and how regular they are, and their relationship to the P waves. So let's try to identify the various waves to see if we can identify them in this rhythm strip. So this is the QRS complex I have circled in yellow. Let's try to see, this is a T wave, so a wave after the QRS, but we don't, the P waves are not very visible, so we can't really identify the P waves here. So the QRS are kind of obvious, QRS complexes are obvious, then we can see some T waves after the QRS complexes. Now let's see the regularity of the QRS complexes. There is a QRS complex here. There is one which I've circled here as well. Then you have this as well. Then this. So you can see the QRS complex, obviously. But if you look at the regularity, the distance between this QRS complex and the distance between this QRS complex are kind of different. And so is the distance between this and that. So the distance seems to be irregular. And so that tells us that this rhythm is not a regular rhythm. So it's an irregular rhythm. And then the irregularity seems to be irregular too, because if you look at this distance here and this distance and this, every distance is different. So you can't predict when the next distance, the next QRS complex is going to come. So it's irregular. The pattern itself is irregular, and the frequency itself is irregular. So it's an irregular rhythm. And the P waves, obviously, we can see the P waves. Okay. Now, the heart rate, we said the methods you use to calculate the heart rate kind of depends on whether the rhythm is regular or not. So there are kind of about 3 different ways of determining the heart rate if it's regular. So this is just a recap of the things I've already underlined there. There are no discernible P waves, and you have your PR interval, your RR interval, which is also what irregular. Now for the heart rate, as I said, 3 different methods if it's regular. If it is regular, you just determine the heart rate by taking one QRS complex and the next QRS complex, and you determine how many big boxes are between them. So in this case, for instance, if the rhythm was regular, there's a QRS complex here, there's another QRS complex here. You kind of determine, and you have about 2.5 boxes in between them. So it will be 300 divided by the number of boxes. So it will be 300 divided by 2.5, and that'll give you your heart rate. Or you could just put a ruler between this R wave and this R wave, and you measure the distance between them in centimeters, and then you divide 150 by that distance. That will also give you your heart rate. And all this is if the rhythm is regular. The third option is to divide this distance by the seconds. So you measure the distance here, the duration between the R wave and the next R wave in duration, so time interval in seconds, and you divide 60 by that time, and that is if the rhythm is regular. But in this case, the rhythm is not regular. So what you do is that if it's not regular, you count the number of QRS complexes in the entire 10-second strip. And because the heart rate is determined in 1 minute, to get your 1 minute, you need 60 seconds. And since the entire strip is 10 seconds, to get 60 seconds, you multiply that by 6. So what you do is you count the number of QRS complexes within the entire 10-second duration, and you multiply by 6. In this strip, when you count all the QRS complexes, you get about 24. You multiply that by 6, and you get 144. So the heart rate in this patient is 144. But this is a range. As we said, the pattern is irregular. It could be that in the next 10 seconds, we got even a more frequent occurrence of the QRS complex, or got even less. So it's a range. So typically it's a range. So you have a range between 144 to 100 and something, or 140. It could be more or it could be less, but it's typically a range. So what are the key findings in this ECG? The key findings is that when you look at these QRS complexes, so they are narrow, the shapes are normal narrow QRS complexes. It's just that the frequency at which they are occurring that is not regular. So you can say that the findings are what? An irregular rhythm. You have no discernible P waves. We can't really see the P waves. And of course, the QRS complexes are narrow, so telling us that whatever impulse is generating these QRS waves is probably coming above the AV nodes. So it's not coming within the ventricles themselves. And so it will give you a narrow QRS complex. And the cardiac axis is normal. Now, cardiac axis determination, usually you use a lead 1 and AVF. If the QRS complexes in lead 1 and AVF are positive, that kind of gives you an idea that the axis could be normal. If you come here, there's a positive QRS complex, and in the lead 1 here too is a positive QRS complex. So it means that this is probably a normal axis, just a rule of thumb. But this is not a module on ECG interpretation. We have a dedicated module on ECG interpretation. So do make sure to check that out for more details on how to interpret ECG. So those are the key findings of this ECG strip. So now let's go back to our question to see how these findings, together with the information from the question stem, can help us in answering the question. Right. So we've already underlined the key information here: elderly patient, palpitation, and recurrent or probably persistent condition and shortness of breath, at the first time when it occurred. Now let's see how the findings from our ECG also helps us. We've said that the heart rate was 144. So with the heart rate of 144, that means that there's tachycardia going on there. And so for an option saying that there's sinus bradycardia, we can rule that out. So because we know there's tachycardia and not a bradycardia. So we rule that on our sinus bradycardia can be ruled out. The impulses are definitely coming from a supraventricular of origin, because we know that because the QRS complexes are narrow. And that means that it is not a ventricular of origin, it's not a ventricular tachycardia. So we can rule out a ventricular tachycardia too. That leaves us with atrial fibrillation, supraventricular tachycardia, and atrial flutter. Now, in atrial flutter, what you tend to see is the P waves tend to appear as what they call them the F waves. They're called the flutter waves. So you have this ECG appearance that looks like what is described as a sawtooth appearance. Clearly, we didn't see that in this ECG. The P waves were not discernible, and there was no flutter waves as seen in atrial flutter. So we can also rule out an atrial flutter in this case. Now that leaves us with atrial fibrillation and supraventricular tachycardia. Now, what are supraventricular tachycardias? It's a term used to describe a group of tachycardias originating from any site above the ventricle. So supra means above, right? So supraventricular tachycardias, it means that origin or the site of the impulse is arising above the ventricle, and which means it could be in the AV node, it could be in the SA node, or it could be even in the myocardium of the atrium, or it could even be from the bundle of hairs. And the bundle of hairs, this is before it bifurcates. So from the AV node, you have the bundle of hairs which bifurcates into your right and left. But before that bifurcation, you can have an impulse originating from that, and that can lead to a supraventricular tachycardia. So because you can have multiple origins of impulses leading to supraventricular tachycardia, is a group. So you now have multiple conditions that are lumped together into that group. So you have atrial tachyarrhythmias, for instance. So atrial flutter is an example of a supraventricular tachycardia. Atrial tachycardia itself is an example of a supraventricular tachycardia. So we have atrial tachycardias, and it could be either focal or multifocal. And atrial fibrillation itself is an example of a supraventricular tachycardia. Then you have reentrant tachycardias like atrioventricular nodal reentrant tachycardias, atrioventricular reciprocating tachycardias, you have junctional tachycardias, there are a whole bunch that come together to form the supraventricular tachycardia. So it's not a single condition, it's a group of conditions that is described by that. Now the trick about best in one MCQ questions is that there's always one best option. That's the idea. The idea is that there should be one best option, but it doesn't necessarily mean that the other options are wrong. It's just that they are not the best option. Okay, so sometimes it's obvious. You can obviously rule out certain conditions, certain options. In this case, as we've done sinus bradycardia, we ruled that out and we had a reason for that. Ventricular tachycardia, we did the same. Atrial flutter, we did the same. But now we are tied between B and C. But the best option here is atrial fibrillation, because we said supraventricular tachycardia is a more broader term and does not really mean a single condition. But we are looking for a single best condition here. So we rule out the supraventricular tachycardia because of that reason, and that leaves us with atrial fibrillation. Now, let's look at some causes of atrial fibrillation. There are numerous causes of atrial fibrillation, but we are going to concentrate on the common causes. A very simple mnemonic you can use to help you remember some of the common causes is parasites. So P, you have pulmonary disease like COPD, pulmonary embolism, you have anemia, rheumatic heart disease, atrial myxoma, sepsis, ischemia, so ischemic heart diseases. And then you have thyroid disease, so hyperthyroidism, external, so alcohol consumption. So people who go out the weekend, go to binge, they binge drink, they end up with these atrial fibrillations. But there are numerous other causes, but with this mnemonic, you are able to remember some of the common ones. Now, let's look at some of the clinical features of atrial fibrillation. We've already talked about a few, but one or two of the conditions that this patient already had. But what you should bear in mind is that for all patients with atrial fibrillation, when you examine them clinically, there will always be an irregular pulse. That's a classic feature of atrial fibrillation. It doesn't mean that's the only condition that can cause that, but it's a classic finding in atrial fibrillation. And there will always be an apex pulse deficit. What does that mean? Apex pulse deficit. What it means is that when you check the heart rate, when you put your stethoscope at the apex of the heart and you read the heart rate, and then you go to check the pulse rate, which is you check using the radial pulse or any other peripheral pulse, there will be a difference. Remember, pulse rate does not necessarily mean heart rate, okay? Pulse rate is what you check in the pulses, so like the peripheral pulses in the arteries. The heart rate is what you read when you put the stethoscope over the chest to hear the heart sound, the heartbeat. And so sometimes when the ventricles are contracting so fast, it doesn't allow enough time, so the duration for diastole becomes shorter. So when the ventricular rate increases, the duration for diastole becomes shorter, and then because it becomes shorter, it doesn't allow enough time for the ventricles to fill. And because the ventricles are not well filled or there's not blood, so preload becomes low, and then that means that cardiac output will be low. And once you have low cardiac output, it means that you will not have enough blood going to the vessels for you to fill a pulse. So the heart is just beating, but not enough blood is going to the blood vessel, so you will not feel a pulse. So when you check the heart rate could be 144, but when you check the pulse could be reading like 110 or 120. So there's an apex pulse deficit, and that is why you typically will see in patients with atrial fibrillation. So an irregular pulse with an apex pulse deficit. And sometimes not all of that is conduct. So the heart rate is you're hearing the heart rate, but you're not feeling any pulse. Right. And most patients with atrial fibrillation are asymptomatic, most of them. But in some patients, some patients might present with symptoms, as in this case, we've seen that the patient presented with palpitations. And 2 years prior to that, he had dyspnea or shortness of breath. But in addition to that, they can also have fatigue, lightheadedness, and then, syncope. And for patients, especially those with underlying heart conditions, for instance, you might pick up signs of those underlying heart conditions, like MNEMOS, for instance, in a patient with rheumatic heart disease. As I said, most patients with atrial fibrillation are asymptomatic, and those who present with symptoms are typically stable. For those who are who tend to present with, in an unstable state, unstable state, are those who have like a very high ventricular response. So it means that the ventricles are contracted really very fast, and as I said, diastole becomes shorter, preload become, ventricular filling becomes impaired, preload is low, cardiac output is reduced, and that leads to all the symptoms. And so when the ventricular response rate is very high, that results in that the person becomes asymptomatic and becomes unstable. Patients who also already have some underlying cardiac condition typically will present with in an unstable state. So somebody with like an ischemic heart disease, for instance, who now goes on to develop atrial fibrillation will probably present in an unstable state. What are some of the differential diagnoses for atrial fibrillation? We can talk about all the differentials for each of the symptoms of atrial fibrillation, but we can't do that. There are numerous of them. What we are going to do is we're going to focus on differential diagnosis of irregular pulse, which is one common question that keeps coming in exams. You tell the examiner that, oh, you picked up an irregular pulse. Oh, nice. Then tell me about differential diagnosis of irregular pulse, because it's quite interesting. But differential diagnosis of atrial fibrillation, you can talk about all the differential diagnosis of palpitations, all the differential diagnosis of dyspnea, syncope, lightheadedness. There are numerous of them. But for the differential diagnosis of irregular pulse, you should know those, and these commonly come in the exam. So those are the ones we're going to talk about. So atrial flutter with a variable conduction rate is a good differential diagnosis for somebody with an irregular pulse. So it means that atrial fibrillation is not the only condition that can cause an irregular pulse. Somebody with an atrial flutter with variable conduction rate. What does that mean? It means that the conduction through the AV node is an atrial flutter. The origin of the impulse causing the arrhythmia is in the atrium, somewhere in the atrium, and it's traveling down to the ventricle through the AV node. And sometimes some of the conduction through the AV node is blocked, and so you have variable conduction. You might have variable conduction. Sometimes the block is actually well determined. So you have like a pattern where the block is occurring. So every other beat is when you have a conduction coming through. So you have 2:1, block. So 2:1 AV block is when we have like every other beat is when you have this atrial flutter coming through. And then you can have 3:1, 4:1. These are like well-determined patterns. So there's an irregular QRS complex, but the pattern is regular. You know when the next irregular QRS complex will appear. Those are regular. So you have a more determined conduction rate. But when the conduction rate is variable, it means that sometimes it blocks, sometimes it doesn't block, sometimes it blocks, sometimes it passes through. You don't know when. So it also becomes like an irregular pattern. So you tend to now have an irregular pulse. The same thing with somebody who has a focal atrial tachycardia with a variable conduction rate. They will also present with an irregular pulse. The same explanation as I gave for the atrial flutter. Now, for people with multifocal atrial tachycardia, for them, they will have an irregular pulse irrespective of the conduction rate, because it is multifocal of origin. So it means that there are multiple origins of the impulses within the atrium, and it's just shooting from all angles. So there will be an irregular pulse. And of course, the SVT, which we said is a term used to describe the group of these conditions. That can also be a differential. So yes, I hope this brief overview was helpful. Do make sure to check out our module on ECG interpretation and arrhythmias for more details on atrial fibrillation and interpretation of ECG.